Alright, so this video is going to be talking about community-acquired pneumonia, which is pretty common, more in the elderly and more in kids, definitely more in those with COPD, more in those who smoke or have asthma. It's going to be something that you're going to see coming into your office. So let's talk about how we would treat a patient with community-acquired pneumonia. First of all, what do these patients look like? So they're going to have a cough, they're going to have mucopurulent sputum, fever, and pruritic chest pain. Why pruritic chest pain? They're coughing so much that they're just not doing good. On the flip side, you can have some elderly that just present with confusion. And some kids that when you listen to their lungs, you hear rails and you think, this just ain't right. So it's primarily in the lower lobes. You can see it in the upper lobes. Why is that? Well, typically the infiltrates fall to the bottom. So you're going to want to do imaging most likely. The thing with X-rays imaging is it does cause radiation, and especially if you have a child who's your patient, you don't want to go straight to imaging because that will affect them more than it would an adult. They're going to get more distressed by it. It doesn't really change your diagnosis, so sometimes you don't need it, sometimes you do. If you're thinking about, do I need this or not, is their heart rate over 100? You want imaging. Is their temperature over 100? You want imaging. Is their respiratory rate over 20? You want imaging. Do they have decreased breath sounds, rales? You want imaging. There are a lot of minor cause pneumonias that you would hardly even know that the patient was having pneumonia, except for they're just having to use their inhaler so much that you're like, So that can be a challenge, but if you do get X-rays, you're going to see infiltrates. So that's the first decision you want to make: to X-ray or not. Typically, blood cultures are not done. You could do sputum cultures; there'd be no problem with that. Blood cultures, really, we're going to think about that for the more serious patients. And the next decision you're going to want to make is, do you want to send them to the hospital or not? Now, patients can definitely be managed outpatient and there not be any issue. Particularly with the bacteria Mycoplasma pneumoniae, which is walking pneumonia. Strep pneumoniae, most likely you can treat outpatient. And then chlamydia pneumonia, you can treat that outpatient. Those are the three most common. And if you are going to treat outpatient, you can do a macrolide and doxycycline, or one or the other, a macrolide or doxycycline. So the macrolides, those are going to be our mycins, so azithromycin, clarithromycin, erythromycin. Well, probably not going to do erythromycin, but you could. Then if the patient has comorbidities, like if they have asthma or COPD, you're going to want to go with a macrolide, definitely. And then if you decide to admit them, you're going to want to do a fluoroquinolone, levofloxacin, gemofloxacin, moxifloxacin. Probably levofloxacin. Moxifloxacin is kind of more of a skin, used to treat acne, but you could do that too. You would want to add a beta-lactam to that and add a macrolide to that, so the azithromycin. So it would be levofloxacin, beta-lactam, azithromycin for those hospitalized patients. And it might change depending on what they're actually infected with. If they're with a pneumonia, you're going to want to change it to something that treats the pneumonia a little better. If they have a MRSA, that's probably not community-acquired pneumonia. A MRSA is more typically hospital-acquired pneumonia, but If you were to have that, you're going to want to go with a vancomycin probably. And then, so how do you decide if you need them to be hospitalized? Are they confused? Do they have a BUN of over 20? Hypertension, hypothermia, leukopenia, multi-lobe infiltrates, if their respirations are above 30, or thrombocytopenia. And there's actually a really helpful mnemonic. Well, I guess it's really not a mnemonic, it's a screening tool. CURB 65, which is pretty popular for going through and saying, do I want to admit this patient? So CURB 65, CURB, and then 65 being age over 65. So if they have confusion, a BUN over 20, a respiratory rate over 33, and a BP over 90. Now, of course, under 90. Of course, if your patient has hypotension or respiratory rate over 30, you're going to feel really uncomfortable sending a patient like that home. But the BUN is kind of telling you, look, they might not be able to metabolize these drugs that you need to give them. So that can be pretty concerning. And it also tells you that they've got a lot of urea in their body that they kind of need to get out. Probably with some fluids if all that's going on. And they've done some studies that show that adding prednisone really doesn't help the overall course, but of course that is an option to add on to this treatment. And then also adding on a SABA or an albuterol, a levoalbuterol, is probably a good idea in those patients that you're going to go ahead and treat outpatient. Now, it's not going to, it's not going to make them get better faster by any means, but if they are having just coughing and can't stop coughing, then the albuterol is going to open up their lungs regardless of, if they have asthma or not, and could potentially be a life-saving treatment. So that's never something you want to skimp on. And you want to keep a close eye on the pneumonia patients. Have them, after starting the antibiotics, have them come in and, 3 days, you want to touch base with them and see how they're doing. Definitely, if they're not seeing symptom improvement in 3 days, you want to consider doing some more diagnostic tests to see, am I treating the right infection? And just ensure that their respiratory rate isn't getting too high. Their blood pressure is staying okay. You want to watch out for making sure that they're not getting towards a septic status. Catch that early and treat it, and these patients will be just fine. So I hope that helps you in your treatment of patients with community-acquired pneumonia.